So we are broadcasting now. The webinar will be starting shortly. As people are coming in, if you want to put in the chat box where you're from, we can let them know. We can read them out. Just another few minutes and we can begin. We have about 20 people on here so far. Again, this will be recorded so people can watch it at a later time. Okay, since it is the top of the hour, we're going to get started. I'd like to introduce myself. I'm Josephine Greener. I'm the Chief Science Officer for the Foundation. I'd also like to introduce my colleague, Helene Baruch, who will be helping me as well. Why am I thinking?
Hi, everyone.
My slides are always getting stuck. Okay, so welcome to the third and final week of the International E3 Summit, Educating, Empowering, and Enriching Our Community. It's being brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and also with our partners from VASCERN. We really want to thank everybody for helping us make history. We have almost 2,800 registrants from 72 different countries. And we really do hope that you had an opportunity to connect with people through the app and can keep or maintain those connections after the summit. So as you know, you're not on this journey alone. We want to thank our presenting sponsors for helping us make this programming available. And it's being brought to you by Brigham and Women's Hospital and American Communication Construction. So before we start the presentations, I'd just like to note that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VASCERN. So if questions arise or clarifications are needed about differences in these opinions, you can contact us on our website at marfan.org/E3Ask, and we can help clarify those things. Just note that we are getting a lot of questions, and so it may take us some time to get back to you. So right now, I would really like to introduce our speakers. We have here Dr. Dianna Milewicz from the University of Texas and Guillaume Jondeau from France with us today. And if you, Dianna, want to say a few words just to say hello?
Yes, hi. Hello from Houston, Texas. Happy to be participating and hopefully be able to get you information about genetic risk for aortic disease.
Dr. Jondeau?
Hi everyone, pleased to be with you from Paris, France, far from the States, but a nice place. And we hope we will be able to provide you with some useful information about your disease or what you're interested in.
Yes. So thank you both very much. So today we do have, as well as the presentation, a personal perspective by one of our board members, Sinclair Lee. And so I'll play that presentation first. Oh, and before that, just want to let everybody know that we really would love your feedback on all the sessions, and you can do that by just pressing the rate button on your app where the red arrow is showing. So let's go to the first presentation. Speakers can mute themselves and turn off.
How are you? Sinclair Lee. I'm coming to you from New York, New York. Hope everybody is well. Just wanted to share a little bit about my story. Really starts back in the mid-'80s. My grandmother passed away of an aortic dissection in her early 60s. Continued into the early 90s where my uncle passed away of an aortic dissection at age 47. My dad followed a couple of years later in 1996 at age 51, and then his older brother passed away 3 years later after that at 57. With my story, I was 34 years old. I went in for my annual checkup with my cardiologist. I had started going after my father had passed, and I would go in once a year for an echocardiogram. And during this visit, it was found that my aorta was enlarged, and I was rushed into emergency aortic dissection surgery. A long recovery, a long process. You know, I went through 3 surgeries, spent 6 weeks in the hospital, battling all sorts of complications, but luckily I made it out. And from there, the initial thought was that I had Marfan's disease. Further genetic testing found out that it was a mutation that caused aortic disease within my family. And subsequently, you know, my 2 sons at that point were tested and found to be positive. Luckily, my brother, my one sibling, was negative, and he doesn't have to worry about this. But, you know, it's been a lifestyle change. You know, the how you take care of yourself, how you exercise, how you work out, everything's in moderation. You know, I think just your behavior in life is moderated. And, you know, my children started taking, well, starting at the age of 3, and they've been on that ever since. And, you know, they have they have annual checkups with their cardiologists, and we stay on top of it. You know, and their lifestyle is going to be limited, but, you know, more importantly, we're proactive with it. We understand it, you know, to the best that we can, and we continue to support this foundation because we do believe that the research is so important, and the development and awareness is, if not as important, more important, just to be able to diagnose it, because I think that's, you know, the key thing is being able to diagnose it and treat it, and being able to live your life in the correct manner so that it's not too impacted and you can, you know, live almost a normal life. You know, I've been with the foundation now for, I believe it's 7 years, and, you know, I continue to spend my time and whatever efforts and abilities that I can to share with the foundation and help them raise money and bring awareness to the community. You know, it's served as a benchmark for sort of my network and my community of friends. who do come to me when, they find out that they have family members or their friends that are, in the early stages of finding out, whether their heart issues are related to this.
I'm Dianna Milewicz, and I'm here to talk to you about heritable thoracic aortic disease and the genes that cause that condition. So for many years, Dr. Jondeau and I and others have been working on thoracic aortic aneurysms and dissections. And an aortic aneurysm is where the aorta, which usually has this size, enlarges, and that's called an aneurysm. And the natural history of these aneurysms is that they progressively enlarge over time, and as they get bigger and bigger, they become unstable, and that can lead to an acute aortic dissection. And that is where the blood goes from inside the aorta, or from the lumen, and tears into the wall and starts dissecting along the wall, so that you've got blood in the inside of the aorta, the true lumen, but you also have a channel, a false channel that's filled with blood. And this can be life-threatening, but we can prevent these life-threatening dissections if we know who's at risk for aneurysms and monitor the aneurysm and repair the aorta. This protocol completely prevents these acute aortic dissections and the premature death and disability associated with them. So my research program has been working for many years trying to identify all the genes in the human genome that predispose to this aortic aneurysms and acute aortic dissection. And once again, the goal is to find if somebody is at risk, we can prevent the dissection by going in and replacing the aorta to prevent the dissection. So for many, many years, we've known that you can just alter one gene in the human genome and cause somebody and give somebody a very, very strong risk for aortic aneurysms and dissections. And we know that from patients with Marfan syndrome with alterations in the FBN1 gene. We can pick these people out of the general population because Marfan syndrome tends to make people grow very tall with very long arms and legs, so they come to medical attention because of that. And another condition defined more recently is Loeys-Dietz syndrome. It's a series of genes that cause this condition, but often the people with the conditions will have features that allow them to be identified. And in this case, they have changes in the way their skulls form, and that changes their facial appearance and brings them to medical attention, and they get diagnosed. But there's many conditions where people look completely normal, but still have that very strong risk for an aortic dissection. And these, and John Ritter, a very well-known comedian and actor, it was one of those individuals. He had an inherited risk for thoracic aortic disease, and that we did not find out until he died of an acute aortic dissection. After his death, we figured out that his father, who was Tex Ritter, one of the original singing cowboys, that he had died suddenly and most likely due to an acute aortic dissection. And Tex's brother was known to have an aneurysm that underwent repair, thus preventing his, therefore preventing his aortic dissection. So here we have a family that doesn't have any of these syndromic features or anything to pick them out of the general population as to being at risk for aortic dissection, except for the fact that there's other family members that have had aneurysms and dissections. So the sort of spectrum of disease from these syndromic causes like Marfan syndrome all the way to families like John Ritter, we term as heritable thoracic aortic disease. In other words, there's a change in the DNA in these families that's being passed from one generation to the next. And that is increasing their risk for aortic aneurysms and dissections. So this risk is typically inherited in families, whether it's Marfan's or families with like John Ritter's family, where there's no syndromic features. It's typically inherited in an autosomal dominant manner. That means that somebody that has the condition shown here as the affected father has a change in their DNA in a single gene. And here that gene, the altered gene is indicated as D, and the unaltered gene is indicated as N. And then the mother has two normal genes. So when they go to have children, the father will pass on either the altered gene or the unaltered gene. And if the child gets the altered gene, that means they're affected. But if they get the unaltered gene from their father, then they're unaffected. So, and then subsequently, this person has a 50-50 risk of passing it on to their children, whereas this person does not, because they have two normal copies of the gene. So if you use the example of Marfan syndrome, somebody with Marfan syndrome has two copies of that FBN1 gene, and one is altered and one is not altered. So they have a 50-50 chance of passing it on to the next generation. So if we take a look at pedigrees, we can follow the disease through the family. So this is actually a family like John Ritter's family. And the pedigrees are, let me just go through, describe a pedigree. Men are in square and women are in circles, shown in circles. A line between them means they're married. A line down means they're children. And so this is a married couple and they have two sons. And if somebody's affected, they're filled in as having, their symbol is filled in, and in this case it's black. And so you can see here, this individual's grandfather had disease. There were two uncles of this individual that had disease. His sister had disease. And so it's being passed from one generation to the next. And that's that autosomal dominant inheritance. And you can also see that his mother had to have carried the altered gene. Grandpa had it. He had it, so it had to come through her, but she does not have any aortic disease, and she's well into her 70s now. And that's called decreased penetrance. And it can happen, and it tends not to happen with patients with Marfan syndrome, but in these families like John Ritter's family, it can happen where it gets passed and from one generation to the next, and it appears to skip an individual in some generations, and that's typically women that have this decreased penetrance. So we did a very simple study, and so we took everybody that came to be operated on for an aneurysm or an acute aortic dissection and asked if they had a family history like this family history. And it turned out that 20% of the patients had a first-degree relative, even though none of these patients that were in this study had Marfan syndrome or Loeys-Dietz. So it means that many people with thoracic aortic disease have an inherited predisposition for the disease. So we've been taking families like this one where there's multiple generations of people affected and going through and trying to identify all the genes that cause this predisposition for thoracic aortic aneurysms and acute aortic dissections. And here's the list of all the genes in the human genome that my research group and others have identified that predispose to thoracic aortic disease. And you see at the top of the list, and we are really focusing on families that don't have significant syndromic features. You see at the top of the list is FBN1 that causes Marfan syndrome. So there's families out there with just thoracic aortic aneurysms and dissection that don't have the skeletal features or the other complications of Marfan syndrome. And the only way we can pick them up is based on that family history and then genetic testing where we find the actual alteration in that FBN1 gene. And then there's other genes. These are all this list of genes here are many of the genes that cause that Loeys-Dietz syndrome. Once again, they can be people that have this aneurysms and dissections in the family, but don't have those features of Loeys-Dietz syndrome. And finally, there's a lot of genes where there's just no Marfan or Loeys-Dietz-like features where when it's altered, it's being passed from generation to generation and increasing the risk for dissection in individuals in the family. So all these genes we've identified are now on genetic testing panels worldwide, and so they can all be tested. So if we take families like the one that I showed you previously, like this family or John Ritter's family, and do testing for all these genes, we only identify the causative gene in about 40% of the families. So we still have a way to go. We still have to find the genes for every single family out there that has this inherited predisposition, so we can use that information to prevent premature deaths due to dissection. So please consider participating in research if you know you have a predisposition in your family and your genetic testing was negative. We'd be happy to have you in our research study. And I just want to put this slide in there to say this is one of the genes that is designated as Loeys-Dietz syndrome. And at one end of the spectrum, you have these kids that have abnormal facial appearance because they have an alteration in the gene, and abnormal formation of their skull, and many other problems. And then you have other people with TGFBR2 that don't look that abnormal, but look like they have Marfan syndrome. And actually, TGFBR2 mutations were originally called Marfan syndrome 2. So sometimes if you have somebody with classic Marfan, even with somebody with classic Marfan syndrome, you may not have an FBN1 mutation, but instead a mutation in TGFBR2. And then there's many people, if not the majority of people, that look completely normal with TGFBR2 mutations. And once again, you wouldn't pick them out. You wouldn't see this woman and think, oh, she's got Loeys-Dietz syndrome. You'd think she was actually very attractive and very normal looking. And it turns out that she has a family history of dissection. She herself had a dissection. You can see her nice, well-healed scar there. And she turned out to have a TGFBR2 mutation. So we really have to go to genetic testing to really figure out what's going on in the families. So genetic testing, who should get this testing? So we think anybody with features of Marfan syndrome and Loeys-Dietz that have an aortic aneurysm or dissection should be tested. People with family histories of aneurysms and dissections should have one person in the family tested. And anybody with an aortic dissection less than 56 years old should have genetic testing. We know from our studies that if we do testing for this group of individuals, about 10% will have an alteration in one of those genes I talked about. And this is aortic dissections in people that have absolutely no family history. So we still pick up these inherited alterations in these inherited genes, even if there's no family history. Before you get tested, you should really ask what your out-of-pocket costs are going to be. Most insurance companies cover it, and the genetic testing companies will tell you exactly what the cost will be, and will work with you for that for covering that. And there are insurance issues that you have to consider before getting testing. You can't, with a positive genetic test, in other words, an alteration or a mutation in one of the genes that one of these genes we're talking about, you cannot be discriminated against in terms of your medical insurance, but they can deny you life insurance and disability insurance. So before we do genetic testing, we talk to our patients about this fact, that for their kids or other individuals in the family that don't have aortic disease yet, if they come back positive, they may not be able to get insurance or disability. So we urge them to consider getting that before the testing's done. You have to do the testing. Ideally, you do the testing in an affected individual in the family. We really want to know we're testing that and the person who's affected so we can pick up that change. If we test somebody unaffected, they could just not have the change that's running in the family. Typically, we just have somebody spit into a tube and get that sent out to the diagnostic labs. And as I mentioned previously, all those genes that we've identified are all tested and sequenced at the same time. And because of that, it usually takes about 4 to 6 weeks to get the results back. This is getting faster and faster, but it still takes time. It's not like running a blood glucose where you can get the results back almost immediately. And so when you do the genetic testing, there's 3 possible outcomes. It can be positive, which means that we have found the causative gene running in the family. It could be negative, and your family it could be one of those families where we don't know the gene yet. And then it can come back that there is a variant of unknown significance in a gene, and that should be treated as a negative result. It means there's a change in one of the known genes, but we just don't know if it causes disease or not. So in the meantime, you should consider your family is negative for genetic testing. But it may be, in a few years from now, we will know, we may determine that particular variant was actually the causative gene, and that would be reported back to you. So I just want to talk a minute, if you have a family history of disease and you've got that negative test or VUS, I think that what we recommend in that case, that all first-degree relatives of people affected in the family need to be imaged for those aneurysms. So we can still prevent the dissections by imaging for aneurysms. And we base the management based on how the aortic disease is running in family members. And so, but the really important thing is that all first-degree relatives need that imaging to see if they have an aneurysm. In fact, the current guidelines recommend anybody with an aneurysm or a dissection have their first-degree relatives imaged. Because it's often not recognized that it's running in a family. For example, with John Ritter's family, it really wasn't recognized it was running in the family because one individual had an aneurysm repaired and another one died suddenly, and most likely due to an aortic dissection. And it wasn't until Don had a dissection that they realized it was running in the family. So we really, really want to prevent deaths due to dissection. So this imaging becomes important if the genetic testing is negative. So identifying the causative gene and running in the family or in yourself is actually incredibly powerful information for you and your family. We can go through and do genetic testing for that variant or mutation in the gene and determining who in the family is at risk for thoracic aortic disease and who is not. And then we can focus our medical and surgical management on those people that are at risk to prevent aortic dissections. But it also helps us predict what's going to happen to you if you carry the altered gene. And Dr. Jondeau and I and others have been working hard on developing gene-based management. In other words, once you have that change in the gene, how do we predict what's going to happen to you going forward and then provide the management that actually prevents other problems? So these gene-based managements are treatment guidelines based on the underlying gene and sometimes even a specific change in the gene. It'll tell us when we have to go in and fix that aortic aneurysm. It'll tell us what risk you'll have for other vascular diseases. And in other words, if you have a thoracic aneurysm and you get it repaired, will you go on to have an aneurysm in your brain or elsewhere in your body? And it will also tell us what type of vascular disease you might go on to have. And to really define these gene-based management, Dr. Guillaume and myself have organized an international aortic consortium called the Montalcino Aortic Consortium, or MAC. Here's one of our recent meetings with everybody there, and we have participants in MAC around the world. And these participants enter in clinical data on patients with mutations in each of the genes that cause an inherited predisposition for thoracic aortic disease, all those heritable thoracic aortic disease genes. And then we can put that information in a database and analyze the data and begin to look at what's the difference between age of onset of the genes, what's the difference between in terms of men and women with these alterations and so on. And I'm going to just show you just quickly a little bit of the data that's come out of the Montalcino Aortic Consortium. We've been publishing papers along the way, and we are getting ready to put in a big composite analysis paper. So here we are, this is a graph where we're looking at the age of onset. So here is age, and this here is the number of people with alterations in that gene, what percent of the people have actually had that event by that age. And we're defining aortic event as a dissection, presenting with a dissection, or coming in for a surgical repair of an aneurysm. And so here, all these different genes are different lines. Each of these different colored lines are different genes. So you can look right away and see that under the age of 20, there's some genes here, 3 genes that don't really have anybody with an aortic event under 20, whereas there's some genes here that have very early onset aortic events. So this is TGFBR2, and the red one is TGFBR1, and then the dark blue one here is ACTA2. So those are the 3 genes where we really have to look carefully and make sure that children do not have problems in childhood. Whereas this one here in orange is SMAD3, another one of those Loeys Dietz genes, but it doesn't really have much in the way of anything until somebody's well in any events, until somebody's well into their mid-20s. And if you ask pediatricians that are following children with aneurysms, they'll tell you they never see a childhood onset SMAD3 patient. So this just gives it, and then you can see over time that a bunch of these genes just fall pretty much right on top of each other in terms of the average age of onset. Let's say if where half the people have had an aortic event. So if you look at these genes, there's no statistical difference, but there's two genes that are much later onset, and that's once again SMAD3, and then the latest onset is a gene called myosin light chain kinase. So you can see that this really tells us a lot about managing these individuals. Like SMAD3 paper, SMAD3 mutation patients, we really don't have to worry about too much until they're over 20. And the same thing with the myosin light chain kinase and so on. So we can also look to see if there's differences between men and women in terms of this age of onset of aortic events. So most of them, overall, there's a little bit difference, but if we take ACTA2, PRKG1, SMAD3, TGFBR1, and TGFBR2, the only gene that really has a dramatic difference is this gene TGFBR1. And the colors are mixed up, but this is men, the pink is men, and the blue is women. And you can see men have a much younger age of onset of aortic events than women. In fact, if you go out to 60, only half the women with the TGFBR1 variant mutation have had an aortic event by the age of 60, whereas the vast majority of men have had an aortic event. So there's a real dramatic difference in terms of age of onset with this particular gene. And then finally, we can look at specific variants and within a gene. So here's ACTA2 and the variants that disrupt a specific part of the gene or portion of the gene that changes a protein called amino acid called arginine 179. And you can see these children have extremely early onset disease compared with the rest of the patients with ACTA2 mutations. So if you diagnose this mutation, you know you can predict the children will have the age of onset under the age of 20, and that you need to really begin to aggressively manage these children even in childhood. And there's such variants both in TGFBR1 and a very similar variant to the ACTA2 in TGFBR2. So even the actual change in the gene helps us predict the age of onset. So, and then finally, other problems with other arteries. We know those Loeys-Dietz syndrome genes shown here, that they can have aneurysm and dissections of other arteries. So we need to look from the head down to the pelvis for aneurysms and dissections elsewhere. ACTA2 mutation patients, the story is very different. There's a few variants in the genes that either cause very early onset strokes or very early onset coronary artery disease. So that's a very different vascular problem than patients with the Loeys-Dietz syndrome. So all this data just tells us how powerful it is to find the causative gene, and it allows us to go into this gene-based management and look at predict when you're going to have a problem. Does your gender make a difference? Does the actual mutation have a difference? And exactly what type of vascular problems would you be predicted to have? So finally, I want you to mention that please consider participating in research. If you have an alteration in a known gene, please contact us about participating in MAC. And then if you don't have a you've done genetic testing, your family, and you have a family history, and the alteration was not found, or you have early dissection, we'd love to have you participate in our research program to find the rest of the genes at UT Health. And for both of these programs, you can contact Ellen Hostetler in my group, and her information's here. So thank you very much.
You can unmute yourself and put your videos back on. So now I would like to, I know that many of you have submitted questions already into the Q&A box within the app, and we can take a look at those, and our presenters will help to answer some of those. And so we'll start by bringing them up on the screen. And oh, I see that Sinclair Lee has also joined us. He gave the patient perspective at the beginning of this presentation. And so if anybody would like to ask questions of him as well, he would be available here to answer those questions. Thanks, Sinclair, for joining up with us. I can't hear you. Go ahead, try again.
Sinclair, you're on mute. There you go.
Still don't hear you. Not sure why that is. So let's see if we can fix that if we get a question. So let me start with the first question. And this one is asked by Cliff. And he says, I have heard that even without a known gene susceptibility, much aortic, I'm assuming he means aortic aneurysm disease, is nevertheless likely to have an unknown genetic root cause. Can you comment on that? And I think, Dianna, you had done some genomic work to look at some genes in that. So do you want to comment on that?
Yes, that's a great question. As I mentioned in the talk, that we know 20%, up to 20% of people with thoracic aortic disease will have an alteration in one single gene that confers a very high risk for dissection and aneurysms and dissections. We don't know all those genes yet. And I think I emphasized that during the presentation. So we're going after identifying, initially identifying all those genes and are working towards that goal. So that's 20% of the people with thoracic aortic disease, but there's another 80% that don't have evidence that they have a high impact change in a single gene. They don't have a family history of the disease, and they don't have syndromic features. And we're only beginning to understand what the genetic alterations are in those individuals. And there's a number of different genetic approaches that we're taking to identify those genetic changes. I really think that in the next 10 years that we will have a composite genetic risk score for everybody in terms of their risk for an aortic dissection. In other words, we'll be able to sequence a portion of the human genome and say, based on your changes in the genome from the rest of the population, you do or don't have an increased risk for dissection, and this is your lifetime risk for dissection. And then finally, this is the way we prevent those dissections. That's really the ultimate goal of my research program, is to get to that point.
A big step in personalized medicine.
Right. So I do think everybody out there, or the vast majority of people that do have a dissection, have some predisposing causes in their genome. And you put that together with some of the major risk factors. The number one risk factor is uncontrolled hypertension. And between those two events, that they end up with an aortic dissection. And so we just need to find all those variants that predispose people to the disease.
Okay, great, thank you. So the next question is asked by Timo, and maybe Dr. Jondeau, you want to see if you want to take this. So he's asking for some statistical analysis here. So if you have 100 people who suffered aortic dissections, how many of these statistically have the diagnosis of Marfan, VEDS, Loeys-Dietz BAV or FAATD? And is there a good scientific paper explaining what disease causes the aorta to fail in numbers per such disease out of the population of all those who have aortic disease? So that's a very long question there. I think Dianna covered a little bit of that first question there in her presentation, but Dr. Jondeau?
Yes, so it's looking at the population the other way around, meaning that you're looking at people who have aortic dissection and you try to find in these people who have a disease which is recognized already. And when you look at the series of aortic dissection which has been published by consortiums like MAC, but specific for aortic dissection like IRAID, International Registry of Aortic Dissection, and you see that they recognize Marfan, what they call Marfan, which is actually all the connective tissue disease put together, in around 4% of the population who had aortic dissection. That's a global number, but I think it does not mean much because it's really depending which population you are looking at. For example, if you are looking at people who are young, then the risk of having a Marfan syndrome or LOSD or vascular adenose is much bigger than if you're looking at people who are older. For example, in their study, nobody above 70 had Marfan syndrome or LOSD or vascular adenose syndrome, whereas it was like, if I remember properly, around 9 or 10% below 40, meaning that it's really depending on the population you're looking at. You cannot really answer this question. The second thing we can say is that these diagnoses are really difficult. Dianna already alluded to the fact that you need to have the genetic, but even without the genetic, you need to be very suspicious to find those patients who have a Marfan syndrome or Ehlers-Danlos or LOSD or whatever. And so you really need to have people like Dianna who is looking for these genes and to have the family screening which is done and which is not always done. And in this series that are reported, it's a diagnosis of Marfan which is done usually in people with syndromic features, meaning only a limited portion of those who have all these genetic diseases. So I guess the message here is it's not a lot. It can be a way of discovering the genes, and the family screening is really crucial in those people. And the chance to find a genetic anomaly is probably larger in younger patients. That's the first part of a response, but we can speak a long time on this question, I guess.
So we've actually taken hundreds of people with dissections and done exome sequencing. Under the age of 56, 10% will have a mutation in one of those known genes for heritable aortic disease. And these are people that are already screened for family history and Marfan syndrome and Loeys-Dietz, and we know they don't have that. And out of that 10%, 5% of them have a mutation in FBN1 and were never diagnosed with Marfan syndrome because they just didn't have those skeletal and other systemic features of Marfan syndrome. So it really indicates, even for people with aortic dissection, that the genetic testing can pick up one of these inherited predisposition, even if there is no history of it in the family. And sometimes that's due to the fact that the mutation is new in that individual, and it's called a de novo change that is not there in their parents. But sometimes it's being passed in the families, and that decreased penetrance means that somebody in previous generations got the mutation and never showed the disease. Or sometimes people in previous generations died suddenly and everybody said, oh, it's a heart attack, and never thought about a dissection. That's what happened in John Ritter's family. So right now, that's why we're recommending genetic testing for people with dissections under the age of 56. And we just don't have the data For over 56, not rigorous data yet to see how often, but we will, we most likely would even pick up mutations in that population, but just at a much lower rate than we do in the younger populations, as Dr. Jondeau mentioned.
Okay.
May I add something about the,
Sure.
because we didn't answer about the bicuspid aortic valve
Yes.
story, which has been a subject of a lot of discussion.
Yes.
Bicuspid aortic valve was felt a long time to be a high risk of aortic dissection. And actually, when you look at people who have a bicuspid aortic valve and you follow them for a long time, you see that the risk of aortic dissection is much lower than what anticipated at the beginning. This is so much true that the surgery which is proposed when the aorta is dilating in these patients, the recommendation has been changed in Europe, and the aortic diameter threshold has increased because we were going to operate on people too early and nothing happened to them. So I guess the bicuspid aortic valve, the message is here, the risk is much lower than what you can find in many places. Don't worry too much.
It's not zero though, so they still need the imaging and the aortic repair, but it's just much lower.
And
And
it
we
needs also
initially
the familial screening
Mhm.
as the others, but the risk is much lower.
Right. All right, great. That's great to know. And it is much more common in the population too. Is that correct?
Yes, 1 or
Yeah.
2% of the population,
Okay.
and very few of the aortic dissections. So,
Okay. Right. Okay. So the next question is asked by Claire, and she's asking, what is the risk for siblings of an LDS patient who share parents that both do not have the specific gene mutation of their LDS child? Is it important that they have a conversation with their doctor about monitoring symptoms? Are they likely to develop symptoms of LDS later in life? And how many or what symptoms should they have before they ask to be tested? Diana, you want to try that?
Yeah, this is a little bit confusing. I'm not,
Yes.
I need to know how the patient was diagnosed with LDS.
Mhm.
LDS, the diagnosis of LDS typically is not made without a genetic change consistent with that diagnosis. So the question is very confusing because most physicians would not diagnose LDS in a child without the genetic testing showing an actual alteration in one of the LDS genes. So I'm not, it's a difficult question to answer.
maybe we can understand this question as what is the risk in parents having a children with a Loeys syndrome, but the parents, none of them have the mutation. And then this is a neo-mutation that Diana was referring to just before, meaning that the parents have no risk to develop later on the features of Loeys because they are not carrying the mutation which appeared for the first time in the children. Maybe this is part of the answer of this question.
And in that case, the
asking,
risk to the other children when it's one of those new changes is actually extremely low.
yeah, I think that was the question about the other siblings of a patient that has it. So, okay, thanks so much for that.
In the School of Genetics, I just asked, they tell 1%. So very low.
Okay. So this one is asked by Allison. Are genes responsible for aortic disease being continually found? Appreciative of this work as it would bring some peace of mind and ability to be aware for families like mine with 3 of us dissected and 2 sampled.
So that's why we continue to do our research. We got to identify all the genes that cause this heritable thoracic aortic disease. So please contact us about participating in research. If your family is like the family described here, we have to find the rest of these genes and we just cannot do it unless people step forward and volunteer to participate. You've already seen there's this long list of genes that cause this disease, and that's called genetic heterogeneity, where there's a lot of genes in the human genome that when they're altered cause exactly the same disease. So when it just makes it more complicated to find the rest of the genes because of this genetic heterogeneity. So the more people that participate, the more power we have to find the remaining genes.
Mm-hmm.
Yeah, and just to stress that, it's really important because it's very effective, meaning that in the last years, all this gene has been discovered in the last 10, 20 years.
Right.
Meaning there is almost one gene every year, one new gene every year. And this is only possible because we have new families and we are working together to try to have the largest family as possible. So
Yeah, we're trying to work collaboratively, worldwide, in part on this multi-gene aortic consortium infrastructure to really cross over data. So Guillaume and his collaborators will have families in France where they're doing exome sequencing. And then we have families here, primarily from the US and Canada, that so we can share data and help confirm genes. So Guillaume's group and mine have published many collaborative studies by putting the data together and increasing our ability to identify new genes and statistically prove they are disease causing.
Mm-hmm.
These are rare diseases. So really, it's really important to have a maximum of persons who are able to help.
Right.
Right. And we can put the link into this app for you, Allison, so you can know how to join the study.
And please put up Ellen's contact information if you can, Jeff.
Yeah, I will do
So
it.
we can, because that kind of flashed by pretty fast.
Okay, we'll do that. So this is asked by Ellie. What are the odds of someone with a genetic mutation, not hereditary, case if Marfan syndrome, giving it to their kids? So I think they're just asking, what is the chance of, if they have Marfan syndrome, what's the chance that they would have kids with it, even though it wasn't something they got from their parents?
So the neo-mutation that we were referring to is the first appearance of a mutation, but once it appeared, it's what was described by Dianna in the talk, meaning that there's a 50% risk for all the children. Right. 50% risk for each of the children to receive the mutation, the chromosome with the mutation from the parent who is affected, even though it's the first time the mutation is appearing in the family.
Mm-hmm. Mm-hmm. Okay, thank you. So maybe one of you can talk a little bit about Stickler syndrome and the genetics about that. Can it knowing the mutation determine the severity of it, or whether it's going to be mild?
I'm not sure Stickler has anything to do with aortic aneurysm, does it?
No, they're not at risk for aortic disease.
Mm-hmm, mm-hmm, mm-hmm.
So there is no risk.
Mm-hmm, mm-hmm.
So Stickler is a condition where they have sort of a distinct facial appearance, hearing loss, a very particular eye abnormality, and then joint problems, but not aortic disease. There's a number of different forms, and there's a number of different genes that can predispose to Stickler syndrome. Each of the genes sort of predicts the downstream complications. Like some of the genes cause more problems with hearing abnormalities, whereas others cause more joint problems. And the genes are inherited in different manners, in different ways. They don't all have that autosomal dominant inheritance that we have for heritable thoracic aortic disease. So there's a lot of information on the websites, including on the Marfan Foundation website, in terms of the different genes. And I know that genetic testing is available for Stickler syndrome.
And it's good for them to get it, because then they may be able to tell, have an idea of what type of issues they would have with that
Right,
specific
and
mutation.
also who else in the family may be at risk.
Okay, okay, great, thank you. So this is a question by Monique. If a family member had a thoracic dissection, does that make me more susceptible to the same? We are affected with Marfan.
Oh, yeah, okay, I take this one. So if somebody has a Marfan syndrome, the risk of the other members of the same family to have a Marfan syndrome are increased, of course. Now, as you saw, Marfan syndrome is related to a specific mutation in the gene. So you know the gene which is causative of the disease, and you can see if someone in the family, someone else, have the mutation in this gene, meaning he has a risk of developing the disease or not. If he does not have the mutation, he does not have the risk. So if somebody has an aortic dissection in relation to Marfan syndrome, and there is a FBN1 mutation, those in the family who do not have the FBN1 mutation do not have the risk. And those with the FBN1 mutation have the risk of having an aortic disease. But now the risk of aortic dissection in patients with Marfan syndrome and the diagnosis is now very, very, very low, because we know how to deal with those patients. We give them beta blockade, we look at the aorta, we make echocardiography, and we replace the aortic root when it's too large. Meaning that actually the risk of aortic dissection now is almost zero in patients with Marfan syndrome, which are diagnosed before any aortic event. This is the importance of the familial screening.
Right.
And we made a study in my group where we were looking at the risk of aortic dissection with the years. And with the years, you see the risk of aortic dissection decreasing, and the indication for aortic root surgery were preventive, prophylactic aortic root increasing. And now aortic dissection in patients we follow are really extremely rare.
Okay, great, thank you. So this one, next question is asked by Mark, and maybe we can also give him Ellen's email so that you can check up on this, because he sent the saliva sample to the Ritter Foundation about 5 years ago, and he wants to know about updates on the study progress. He has 3 generations affected with aneurysms, and so.
So that would have ended up in my laboratory, since we run the John Ritter Research Program here in Houston. Thank you very much for participating in the research. We've been sending out routine updates to the people participating in the study. So if you're not getting those email updates, please contact us and we'll get you on our make sure that you're on our mailing list. And then also provide you with an update in terms of what's going on with your sample. Please, if you've participated in our study and you haven't gotten an answer, feel free to contact us and we'll give you an idea, where we are in terms of your family. If we have found the disease-causing gene, we do let you know and provide that information back to you and your family. So if you haven't heard from us, it means that we haven't found the causative gene.
Okay. So this question is, are mutations in the MY11 gene related to VEDS?
No, the alterations in MYH11 do not cause vascular Ehlers-Danlos syndrome or VEDS. They do cause heritable thoracic aortic disease. There are lots and lots of rare variants in MYH11 that do not cause any heritable vascular disease, and just a few of those variants actually cause heritable thoracic aortic disease. So I think they probably need to talk carefully with the geneticist or doctor that ordered the genetic testing to understand if they do have a change in MYH11, what is the significance for them and their family.
But this is not usually a very easy answer.
Right.
Well, the answer is usually it's a VUS, and we don't know if it's causing disease or not. We actually have a very large study going on where we've tried to collect as many of those variants out there and classify which are VUSs and which are disease causing, and we hope to get that paper out in the next few months. But the answer is that it's just a rare variant in MYH11 that we can say is absolutely causing heritable thoracic aortic disease. There may be that the other variants are some of those low risk variants that do increase the risk for aortic dissection, but we're still working on that.
Okay. I see we're just past the hour. We have maybe another few questions. Would you mind staying on just a little bit longer?
Yeah,
No problem.
that's
Okay.
fine. I'm going to text to let them know I'll be late for the next meeting. Just give me a minute.
So Jondeau, maybe you can take a look at this one. What are the odds of being 3 siblings all born with Stickler syndrome?
No, I cannot really answer this one because it has nothing to do with the aorta.
So there's different ways that Stickler syndrome is inherited, but in all the different ways, it would not be unusual. I mean, it's consistent with multiple siblings being affected.
Okay.
So what's the odds? It just depends how many children you have and how the gene is inherited.
Right. And I think this question by Sue, you covered very well in your presentation about all the new genes that are associated with aortic disease. So I think we can go on to the next one. This one is by Elaine. Do you consider the risk involved with those affected by a FLNA mutation, loss of function, the same as the mutations in Marfan and LDS?
Filamin A is a difficult story also. It's a gene which is usually responsible for neurologic features, and there can be some aortic involvement, but usually less than with the other genes that are referred to, like those of Marfan's or Loisted syndrome. But we have people with aortic aneurysm in relation with filamin A, and we even heard stories about people having aortic dissection with filamin A mutation, but this is much rarer than what we see with the Marfan syndrome and Loisted syndrome. But this is really experience from people I'm working with. I'm not aware of any definitive study on this population. Dianna, do you have any idea?
So we've launched in MAC trying to collect clinical data and individuals that have alterations in the FLNA gene. So give us a year or two and we'll get that answer out there. Because we just have to collect all the data and then be able to sort through the data and figure out what alterations actually cause aortic disease and what the risk is. This gene is also on the X chromosome, so it's inherited in families in a different manner. So that also complicates the picture. Filamin A also causes some neurologic problems and other issues. So typically these individuals are picked up for issues other than aortic disease and undergo genetic testing, and the alteration in this gene is found.
Okay, great. I think the next question is a little bit difficult to answer because he's talking about that he has Marfan syndrome and his sister's parents recently got tested, but they don't have the results yet. So how do I go about getting results for studies? I mean, I assume you're talking about research studies, or is there a consent to be put into studies as soon as one is tested? So just so that they know, once you get a genetic test, that's not automatically putting you into any research study. You would have to consent to be in a research study so that they can look at your specific medical records and get information from it. Correct?
Correct, exactly.
Okay. All right. The next one is, how do we find medical professionals in our specific area? Judy, we can help you with that through our nurse and our help center. So we'll give you the link for that. You know, about the next decade of research, you know, can CRISPR-Cas9 be used to alter genes that cause TAAD?
This is a great question, and something that we've been considering in terms of some of the alterations that cause very severe early onset disease, where the disease causes death under the age of 30, vascular disease death. I don't think it's going to be pursued in the case anytime soon in the case of your typical Marfan syndrome or other families with heritable thoracic aortic disease, because we already have a way to prevent the deadly complications of the thoracic aortic disease, and that's to go in and repair the aorta to prevent the dissections. So it may be a little bit longer for heritable disease, but it's certainly something that in the future may be a way. So you have this one change in one gene, and CRISPR-Cas gives us the technology to go in and actually correct that gene so the people would not have the disease. But you'd have to go into very specific cells in the vascular and the arteries to correct the gene, and we don't really have good technology to do that yet. And there's some ethical issues in terms of will it cause alterations elsewhere that may increase your risk for cancer, or go into the germline and alter the sperm and the eggs, and that cause further problems in the next generation. So all these things need to be addressed before we can take anything like this into the clinic. But it's already working for other diseases where we can take the cells out of somebody, alter it in the lab, and then put the cells back, like bone marrow cells. So, you know, it's out there, but I think that thank goodness for this particular condition, we have a way already to prevent you know, premature death due to dissection.
Right, right. And the last question here is typical of, you know, how do they, you know, classify or change a VUS into something that is more disease causing, because this person has a VUS in the TGFBR1 gene along with her twin, but now her son and their daughter also have aortic aneurysms. So what should be done with that, and how would that be classified going forward?
Just over time, we will be able to classify the vast majority of these VUSs. It's just going to take time. If you go back to your doctor who did the genetic testing, it may help to look at segregation in the family. In other words, does everybody with the aortic disease have the same alteration? And that information may be helpful in determining whether this VUS is actually disease causing. In other words, if you and your son both have aortic disease, but you have the VUS and he doesn't, then we can say, oh, it's not disease causing in your family.
Right.
But if you both do, and your daughter does, and your twin has it, then that becomes accumulated data that it is disease causing. It may not be enough to say absolutely, but remember there's other data out there that we're all trying to put in international databases that we can go in and start looking at this information and figuring this out. And remember that, you know, we send testing to one lab that calls a variant of VUS, with another lab would call it disease causing. So there's even not consistency within our specialty in terms of the variants, which variants cause disease and which don't. So I'm hoping all that gets sorted out in the next, you know, the next 5 to 10 years. but not much help for you immediately.
Right.
And
Right.
probably the thing here is also the more people you have from the same family, the more information you get, and the more you will be able to answer this difficult question.
Right.
Enlarging the family is part of the answer.
Agree.
All right. Thank you so much. We've answered all the questions. I have a few more slides to go through. If before I do that, would you like to both say any last words to our participants?
Well, thank you, Joe, and the Marfan Foundation for arranging this. This is a great forum to really provide information around the world, and it's been amazing how many people have signed up for these sessions. It's actually kind of a positive impact of COVID when you think about it.
Right, right.
We're the John Ritter Foundation and the Genetic Association for Thoracic Aortic Disease of Canada are hosting a week-long events for International Aortic Dissection Awareness Week, which starts on September 19th. Please see the John Ritter site or the GATA site for information about those events. These are really focused at individuals that have survived dissections or families that have dissections running in the family. And we really want to provide up-to-date medical information on, and also information on living with dissections. There's a lot of stress and depression associated with the dissection. There is issues in terms of what can you do after dissections and in terms of activities. How does COVID affect the fact that you've had a dissection? And we really want to use this forum to answer those questions, but also provide peer-to-peer support. So there are support workshops during this also. Mm-hmm. So look for that week starting on September 19th, which is International Aortic Dissection Awareness Day.
Mm-hmm. Great, great. Jondeau, any last words?
Yeah, thank you. First, for inviting me to participate in this session with Dianna, who is really the chief in this domain, and we've been able to answer the question very well. I'm very pleased as representing Europe to participate in this meeting and enlarging the scope of this presentation, and we will do that next year again, and we'll try to do that for the next awareness day on aortic dissection. Mm-hmm. Last message I want to give is really an optimistic one, because if you look at what was done in the last years, it's really incredible how far we've been. We didn't know anything. We didn't know anything. Just people were dying. We did not understanding why, and then we discovered FBN1, then TGF2, and in the last years we discovered many genes, and through collaborative efforts works that make the power of the research really increasing. And this is now on, and it will be a tool for future progress, which is really, which we can expect to go very rapidly now. Mm-hmm. So I agree with Dianna that we are in the phase where we learn a lot and we make a lot of progress, and all the difficulty that we have are not going to disappear like that, but we discover and we understand more and more. Now we understand why people have aortic aneurysm. We understand the pathophysiology, so we know which are the genes where we should be looking at. This is also helping us. So really, I want to be optimistic about the progress that we made and we are going to make in the coming years. And thank you again.
Yes, that's a perfect way to end this session. Thank you so much for both of your time and the information. It was really, really great. So I just have a few more slides, but if you need to go to another meeting, that is fine. I don't, that would be great. So just some final thoughts here. We went through all the questions. We will be putting some links in there as we discussed, just so you get information that you requested. If you have other kinds of questions, you can certainly send them to us at marfan.org/E3ask. Please complete the session survey. In addition to the session survey, we encourage everybody that participated in the E3 Summit to do the overall summit survey. So whether you attended one session or all 70, your input is invaluable to us, helping us build our programs and services that meet your needs. So to show your appreciation for your responses, 3 E3 Summit survey submissions will be selected at random to win a $50 US prepaid international debit card. So don't wait to submit your survey. Only the survey submitted by 11 p.m. Eastern on Wednesday, September 16th will be eligible for the drawing. And the survey can be accessed by marfan.org/E3 survey or by clicking on the link on the E3 Summit homepage, okay? Also, since the last couple of days, visit our exhibitors in the virtual exhibit hall, connect with your community throughout the app. If you're on social media, use the hashtag E3Summit20 to tag us. And if you want to help make more programming possible, any donations are truly appreciated at marfan.org/donate. As Dianna mentioned, there is an Aortic Disease Awareness Week. It is September 19th through the 26th. It is a worldwide event, and it is powered by the Marfan Foundation. And we hope you'll all participate in our awareness project about raising your hands to raise awareness of the risk factors for aortic disease. Information is available on the Summit app and on our website and in social media. So again, thank you so much to our presenters, and thank you for participating today. So long all.